Hello, I'm Dr. Charles Vega from the University of California at Irvine, and welcome to this program on the management of influenza. Now, influenza usually causes millions of cases around the United States each year, hundreds of thousands of hospitalizations, and it's still the 8th leading cause of mortality in the United States. But what happened this past flu season? There was no flu season. And so that was really remarkable. So it was a historically low incidence of flu in the United States, and it paralleled what happened in the southern hemisphere during the summer of 2020. And thank goodness, because to have a high flu season along with a COVID-19 pandemic would have been an absolute disaster. You know, of course, how did this happen? How did we manage to escape having a significant flu season? Well, I think it was a lot of that public health measures that we were taking to prevent the spread of COVID-19, wearing a mask, washing our hands, that physical distancing. Those all played a role. The school closures, helped because kids can really spread influenza, and not just amongst themselves, but they pass on to their grandparents where it can inflict a lot of damage. And then travel, the fact that there weren't many people traveling, that probably played some role as well. It was not vaccinations. The early reports on vaccination rates from the 2020-21 flu season showed that there actually was a slight reduction in terms of kids getting vaccinated and a slight increase in adults getting vaccinated. But we need to do a much better job with covering vaccines, especially in those at high risk for complications. It's particularly important to protect those at the highest risk of complications from influenza. And in my family medicine practice, these are the patients that I see every day. So it starts with demographic groups, kids under 5, age 65 and older, huge groups of patients. Pregnant women, those in long-term care facilities probably have the highest risk overall of complications of influenza, and that's where influenza can do the most damage, is say in a nursing home. Big demographic groups as well include people of color. So that includes Black, Latinx, American Indian, Alaska Native, all at higher risk for complications of influenza. Severe obesity is a risk factor. And then finally, the other main category I like to focus on is a broad one. And the way I think about it is this. If you have significant chronic dysfunction of any major organ in the body, brain, cerebral palsy or stroke, heart, especially heart failure, lungs, asthma, COPD, if you have chronic kidney disease, if you have cirrhosis, if you have diabetes, all of those are also high-risk conditions for complications of influenza. So putting it all together, again, it's the patients I see every day, and therefore I really want to make sure these individuals get vaccinated. That's the primary goal in terms of the way we prevent the complications of influenza overall. But I'm also going to think about early recognition and treatment of influenza. But we're not doing a great job of that. There's a study that showed over 5 years of influenza seasons that the rate of individuals receiving an antiviral who presented on time within 48 hours of the onset of illness, who were at high risk for complications, and even had a laboratory-confirmed influenza test was only 37%. Now, how many of that same group received antibiotics against bacteria? 28%. And those antibiotic prescriptions were probably inappropriate, leading to more side effects, leading towards greater resistance of bacteria, where an antiviral against influenza really can keep your patient out of the ED, can keep them out of the hospital and the ICU. So we need to do a better job, there's no doubt about it. And it is kind of broken down into two different, I think, sets of priorities. For my patients, their priority in looking for a potential treatment for influenza is feeling better. You know, they're miserable. I totally get that. And I want them to feel better too. Symptom improvement, symptom resolution is a very important goal of therapy. But so many of my patients are at high risk for complications of influenza. I really also want to reduce that risk of getting a pneumonia, of getting a myocarditis. I've seen these cases from my clinic, and they can be absolutely devastating. Patients who get, if they're already older and frail with multiple comorbid illnesses, then you get admitted for a complication of influenza. It's going to take you a long time to recover and get back to that normal state of function. And some of my patients never really recover, and they require long-term care. So getting on the infection early and initiating treatment can mitigate against that phenomenon. But it's really been difficult, especially over the past 16 months or so, in terms of differentiating influenza from COVID-19, how do you do it? On a clinical level, it's nearly impossible. The symptoms look too similar and the profiles are too close. So therefore, testing is required. So getting hopefully a RT-PCR test that can test simultaneously for both influenza and for COVID-19. Now, these tests do exist. They're not always available, but certainly for hospitalized patients, everybody should be getting tested for both when they present with either influenza-like illness or symptoms consistent with COVID-19. The two are pretty similar. COVID-19 has a longer incubation period. It tends to last longer in terms of its duration of symptoms, particularly systemic symptoms such as fatigue, but cough, myalgia, fever. There's just not enough to differentiate between COVID-19 and influenza based on clinical grounds, and that's both in adults and in kids. Influenza does come on and it kind of hits you like a truck. A lot of patients can identify exactly where and when they were when they developed the symptoms of influenza. And they're going to be miserable for at least 3 or 4 days with a fever and the myalgia. And it's more systemic symptoms, right? It's fever, it's myalgia, it's fatigue, just like COVID-19. And cough is ubiquitous as well. But then those symptoms tend to abate. Usually by day 4, day 5, those symptoms that the patient's experiencing where they're having those systemic symptoms tend to get better, and then they tend to improve there. The cough may continue, but if they're still having symptoms on day 6, 7 of fever and myalgia, I'm getting a little bit worried about whether they might be having a secondary complication such as pneumonia, or maybe they have co-infection with COVID-19 as well. And hopefully we tested for that at the outset. But these infections are different from the common cold. I have seen a few common colds. I was so disappointed. We actually had a cold in my house in November, and we'd gone so long with my young kids. It had been a remarkable journey without an upper respiratory infection, so it was personally kind of disappointing. But I recognized it as a cold because it was really the sore throat, runny nose, sneezing, no fever, none of the myalgia, none of the severe fatigue. And so I can differentiate a common cold based on some clinical grounds. Much harder to do so between influenza and COVID-19 specifically. Got to test on those. So let's talk about testing because it is a little bit confusing. CDC has issued guidance because they really want to get treatment on board for those individuals, particularly at high risk for complications of influenza. What they say is that if you have a patient in front of you who has influenza-like illness, influenza is circulating in your community, which this past season it was not, and they're at high risk for complications, you don't have to test that individual. Partly because the testing that we've traditionally used in outpatient settings it has limitations, but partly because we should be getting more of these antivirals out there. Antivirals are different from antibacterials. You don't have to worry about engendering resistance to the virus as much with antivirals, and they're pretty well tolerated. So we should be treating more patients who have influenza with anti-influenza drugs. So again, circulating virus, symptomatic patient, high risk for complications, you can go ahead and treat. But this past year, really, it's been a test strategy. Now, testing, if you have a high-risk individual, shouldn't necessarily stop you from ordering an anti-influenza drug. So I could give an anti-influenza drug while I'm awaiting the results of their send-out RT-PCR testing, for example, for COVID-19 and for influenza, and then stop the anti-influenza drug once I get the negative result back from that RT-PCR. For hospitalized patients, different story. They should all be tested always for COVID-19 and influenza. So while we were co-testing everybody this past season, when we see higher rates of influenza, we're also going to initiate treatment with anti-influenza drug. And of course, follow the COVID-19, that is going to dictate another course of therapy. Maybe we're going to think about monoclonal antibodies. We're certainly going to think about how the patient's moving through the world and how they isolate and how long they'll be isolated. All very important considerations for the home as well as just the public good. Again, I think it's important to realize that if you have that high-risk individual, you can break the 48-hour window. So the labeling on all anti-influenza drugs says initiate within 48 hours of onset of symptoms. But for CDC, IDSA, the Infectious Disease Society of America, state that it's okay to move past 48 hours if you have a individual at high risk for complications. So in hospitalized patients, even 4 or 5 days after the onset of symptoms, we'll initiate anti-influenza therapy because we're trying to draw down the risk of pneumonia and other complications. So it's really about complication prevention at that point. What about the unicorn patient who comes in and they don't have any of those high-risk conditions? I do see a few of these patients, but as the unicorn label implies, they're rare. But I still want to offer them treatment. So if they present within 48 hours of onset of influenza, and I highly suspect influenza, or I have a positive test for influenza, I'm gonna recommend treatment. For them, it's not quite as imperative because there we're really looking at symptom relief. We're not, because they're low risk for complications, I'm not as concerned about the risk of pneumonia, myocarditis, et cetera. But I think that knowing that the influenza drugs, anti-influenza drugs, can get you better by about a day sooner, that's really important to a lot of people, and they may be miserable. So at least offering treatment is worthwhile for those folks. Again, for the folks who are at high risk for complications, I'm really going to strongly recommend and really push that they start an anti-influenza drug right away. The traditional test that we use in the outpatient setting, the Rapid Influenza Diagnostic Test, or RIDT, does have limitations. The good news about influenza testing across the board is they have a good specificity. So if you get a positive result, you can feel pretty sure if influenza is circulating in your community that it's a true positive. However, RIDTs have a pretty poor sensitivity, somewhere between 50 and 60% on average. And so therefore, when you get a false negative result, many times we're not exactly sure what to do with it, and that's really why they should be being phased out from practice overall. There are some newer tests available which also provide a pretty rapid response, nucleic acid amplification tests that do have a much improved sensitivity, around 90% or so. But this is not broadly available in clinical practice, and even though there are machines that can give you a result within 30 minutes, I don't know if a lot of outpatient settings really have those. And if you send it out for a great test like a RT-PCR test, oftentimes you're not going to get results back for 2 days, maybe even 3 days, which is obviously not good because we're trying to get treatment on board as soon as possible, right? So in those cases, if you have that high-risk patient, write for your anti-influenza drug and get the test results. You can always stop the drug after you receive those results. Let's talk about treatment options for influenza. There are some advances over the past several years in this area, so it's worth focusing on those. And it's nice. We have multiple choices. We have the neuraminidase inhibitors, and we have a lot of experience with those drugs. They've been around for over 20 years now. And they're effective and they're well tolerated. Oseltamivir is definitely the market leader. There's peramivir, which is a IV form of a neuraminidase inhibitor, and zanamivir, which is the inhaled form of a neuraminidase inhibitor. And then there's also a newer kid on the block, and this works in a different mechanism compared to those neuraminidase inhibitors, and it's called Biloxeviir marvoxil. And so, maybe we could take a second in a moment to focus on how they work, but let's just go over some of the logistics of how you might prescribe these drugs. So as I mentioned, oseltamivir, it can be used really for any age. We've used it during the newborn period. It's been given to 99-year-olds. We know it very well and how effective and safe it is. It is the preferred agent in pregnancy as well, twice daily for 5 days. Zanamivir doesn't have the market share that oseltamivir does, and I understand from my personal practice. One, it should be avoided in individuals with chronic lung disease like asthma or COPD. Second, you have to prime it, inhale it, and that can be difficult, particularly for some of my older patients who have maybe some cognitive issues. They may have motor issues, they have arthritis, just not as popular to take an inhaled drug, but it is twice daily for 5 days as well. And then peramivir is the IV form, and that's used in the hospital only. And even there, when I talk to my colleagues in infectious disease and critical care medicine, they tell me that really if the patient can take oral pills, they're sticking with a drug like Biloxeviir or oseltamivir. And so, because peramivir is pretty expensive, and so, but it is helpful for those individuals who can't take oral drugs. Now, Biloxeviir is different, and it's certainly dosed differently. Its claim to fame is that it is a one-time dose. That's not once daily. It's one and done. So you take one pill, one treatment, and you're finished. And because it has a very long half-life, and so it's indicated for age 12 and up. Now let's take a look at the pathogenesis of influenza and how Biloxeviir works against it.
After the influenza virus is breathed into the airways, a viral glycoprotein called hemagglutinin facilitates its intrusion into a host cell. Viral genetic material is then transported into the nucleus. Once there, the influenza RNA polymerase complex, composed of 3 subunits, PA, PB1, and PB2, is responsible for both viral messenger RNA transcription and viral replication. The influenza virus requires one small piece of a host cell messenger RNA, called a cap, to trigger viral transcription. It takes this cap in a process called cap snatching. Once the host cap has been stolen, transcription of viral messenger RNA can be initiated. Following viral protein synthesis and RNA genome replication, all new viral components are finally assembled at the cell membrane and initiate the budding of new viral particles. Finally, viral neuraminidase cuts the viral particle free for it to infect other cells, and the cycle continues. Biloxevier blocks an early stage of the influenza life cycle. Biloxevier binds to the PA subunit of the RNA polymerase complex and prevents cap snatching. Without the crucial cap, viral replication is inhibited.
So I think it's great to have different anti-influenza drugs that work in different mechanisms because we don't know when the next influenza pandemic is coming. I hope it wasn't this past year, thank goodness. I hope it's not next year either as we kind of work our way through COVID-19. But it is coming. One of these days it will come. And resistance rates against one of these antivirals will spike. They've been very low the past several years, but they will come back again. To have different agents with different mechanisms of action will really be helpful in that setting because we'll be able to hopefully treat people effectively, even though resistance, say, to Biloxevier or oseltamivir may be high. We could use the drug, obviously, where there's less resistance. Patients want to improve their symptoms. I covered that earlier, and rightfully so. But it's a little bit of a wah-wah moment when it comes to the application of anti-influenza drugs is they improve symptoms by about a day. And for some people, that's really important. They have a big deadline at work, there's a test coming up, there's a wedding, maybe people are going to weddings again now. And so those are reasons a day, feeling better sooner by a day might be really important. Remember that for those at high risk for complications, I'm really going to push this not just for the symptom improvement, but because I'm worried about the risk of complications of influenza as well. Kids tend to get better faster than adults when they receive a drug like oseltamivir. And there was an interesting study out of England this past year that looked at community-based practices, which showed that older adults, who are really the ones who are at high risk for complications, also did better than younger adults on a drug like oseltamivir, getting better sooner by 2 to 3 days. And if you can get these drugs on board, we know within 12 or 24 hours, hard to do logistically, but yeah, then you can expect a 2 to 3 day improvement of symptoms versus placebo. And that's something I think that folks can sink their teeth into a little bit more. I think all anti-influenza drugs are pretty well tolerated, but it is important to think about adverse events. Oseltamivir has one, and the main concern is going to be nausea and vomiting. It affects slightly less than 10% of individuals who get it. You can usually resolve that adverse event by taking the medicine with food, but maybe for somebody who has a history of nausea or vomiting with oseltamivir, or is presenting with nausea or vomiting as part of their syndrome of influenza, because that does happen in influenza, oseltamivir might not be the best choice. Biloxevier, lower rates of nausea and vomiting could be a better choice. And peramivir can cause some diarrhea, so that's a concern there. Biloxevier, since it is new, it's worth covering a little bit more, but it's also interesting because it's one of the few times I can think of where you have a very common problem like influenza, and you have a randomized placebo-controlled trial that includes not one, but 2 good active comparator agents together. So Capstone I took a look at individuals who were 12 to 64 years of age, over 1,000 of them, and randomized them to Biloxevier, to oseltamivir, or to placebo. And the main thing they were looking at was time to alleviation of symptoms. And the main outcome is that, as I mentioned earlier, Biloxevier reduced symptoms. It was more effective than placebo. It reduced symptoms versus placebo by about a day. Patients got better about a day sooner. And there was also reduced fever among individuals who took Biloxevier. And Biloxevier and oseltamivir in Capstone I were similarly effective in time to alleviation of symptoms. What was more effective in the Biloxevier group versus both placebo and oseltamivir was the viral load reduction. So in every study that I've seen that compares Biloxevier and oseltamivir, Biloxevier is associated with a faster reduction in viral load. That might be because it works at an earlier stage of the viral replication cycle. And it's kind of exciting to think about, well, gee, if that's true, maybe Biloxevier reduces household and maybe even community transmission of influenza versus a good drug like oseltamivir. That study is underway, and I'd like to see what the results are because that could be something of a game changer in terms of reducing the overall burden of influenza. In terms of side effects, Biloxeviir is very well tolerated, just like really oseltamivir is as well. You will see lower rates of nausea, vomiting with Biloxeviir versus oseltamivir, and versus placebo, they're generally pretty similar in terms of the side effect profile compared with placebo. What about those individuals, again, who are at higher risk for complications? Well, Capstone II was the largest clinical trial engaged exclusively with individuals at high risk for complications of influenza. So a lot of older individuals, a lot of folks with chronic respiratory illness, and again, a great design, randomized to oseltamivir, Biloxeviir, or placebo. And so what they found was that, again, Biloxeviir was superior to placebo in terms of time to alleviation of symptoms. It was similar, again, to oseltamivir in this outcome. But they went a step further because, again, symptom reduction is great, but the other goal for treatment is reduction of complications, and they showed that. The rate of complications among individuals in the placebo group was about 10%, where it was slightly under 3% in the Biloxeviir group. So Biloxeviir and oseltamivir also was numerically similar to Biloxeviir in this outcome. Both those agents appeared to reduce complications. They also reduced inappropriate they reduced antibiotic use overall, which is probably a lot of inappropriate antibiotic use and stuff that was not necessary overall because the patient really had an influenza infection as opposed to a bacterial infection. I mentioned that one limitation on Biloxeviir is the fact that it's indicated only for individuals 12 years of age and older, but there is data on children down to age 1 with Biloxeviir. So Ministone enrolled children between 1 and 12 years old with influenza. They were randomized to either Biloxeviir or oseltamivir. Would not be ethical to have a placebo group in this particular trial. And what they found was that the two agents were safe. They were well tolerated, and that was really the primary outcome of the study. They also found that in terms of efficacy and reduction of symptoms that oseltamivir and Biloxeviir were similar overall. In addition, in terms of tolerability, kids tend to have more vomiting with influenza and with medication use than adults, and there was a difference in terms of nausea and vomiting with Biloxeviir versus oseltamivir. Oseltamivir promotes more nausea, vomiting than Biloxeviir. The best antiviral against influenza is the one you can get on board right away. So this is not the time to be filling out a prior authorization. It's not the time because the pharmacy is having a shortage of one of these drugs, and it's going to take 2 days to get a new shipment. You can't wait. You want to impart to the patient, if you have any difficulty getting this drug, go ahead and give us a call, and we can do a new prescription or send it to a different pharmacy because you do not want to wait, especially in individuals at high risk for complications. And so one way I kind of put a carrot in front of patients is, hey, if you start this sooner, you'll get better faster. It is important to consider that that influenza is very transmissible within households. There's a pretty high attack rate. And so, they might live with somebody who is at higher risk. So, you might feel fairly invincible. But what about your 84-year-old grandfather, for example? So it's important to consider prophylaxis because prophylaxis really does work, and I'll talk about that in a second. CDC set some guidelines for who should receive prophylaxis, and there's a few steps to take. So first, the individual who's considered for prophylaxis should have significant contact with somebody with influenza within the past 48 hours. If that contact was 4 days ago, no, don't treat them. You can also watch and wait as a perfectly reasonable strategy, and then the second the patient starts to feel sick, they let you know and you initiate anti-influenza treatment. So, as well with the CDC guidelines, this is the only time that whether the patient was vaccinated or not actually plays a difference in the guidelines. When it comes to treatment of active influenza, whether you're vaccinated or not, doesn't really play into that calculus because we know that the influenza vaccine isn't highly effective. It's anywhere between 40% effective, usually to 60% effective in a given year, usually under 50%. But here, prophylaxis should really be reserved for those who have not received a vaccine or received the vaccine within the past 2 weeks, and therefore it's not likely to be effective, or they have significant immunocompromise, and the vaccine won't engender the type of protection that it would for for somebody who's not immunocompromised. So that's the criteria. So they have to have exposure within 48 hours. They have to be unvaccinated or a vaccine that's presumed not to work yet, and they have to be at high risk for complications of influenza. And then and only then the CDC says you can initiate prophylaxis. But prophylaxis really does work. When we look at oseltamivir and zanamivir, which are mainstays for prophylaxis over the past couple of decades, they have efficacy, that's above 80% overall in terms of prevention of household transmission of influenza. They're good drugs. Remember, this is where they're dosed for prophylaxis just once a day instead of twice a day, and they should be taken for 7 days after that exposure. I find that a lot of patients don't complete that 7-day course, but Biloxevier has come and now has an indication for prophylaxis as well, and so that's pretty great. It's based on the results of the Capstone study, and so this is where individuals who are household contacts of a case of influenza received either placebo or Biloxevier, again, one-time dose only, and they found that overall the efficacy in prevention of household transmission of influenza associated with Biloxevier was 86%, so right there with our older agents, zanamivir and oseltamivir. It's effective too. The benefit being this is a one-time dose again, so one time and you're prophylaxed. Don't have to take a drug for 7 days. So, and even in subgroups, it was found to be significantly superior to placebo. So prophylaxis is something we should not forget about. And the most important place to consider prophylaxis, long-term care facilities, because again, that's where influenza can spread like wildfire and put not just one, but usually several people in the hospital, unfortunately. It was well tolerated as it was in its clinical trials for active illness, so I think that was fantastic. So what are the take-home messages regarding the management of influenza? Well, first, get the vaccine on board. It is critical. For high-risk individuals in particular, I really tried to identify a time, usually at the end of September to the beginning of November is the prime time for them to get the influenza vaccination, but any time is better than no time. And so we really want to see the influenza vaccination rates increase across the country. I also want to impart to them that if you have the acute onset of myalgia, fever, fatigue, cough, contact us right away, because particularly if you're at high risk for complications of influenza, I want to get treatment on board as soon as possible. Now, I am going to test right now in our current environment when influenza is circulating for both COVID-19 and for influenza, but I'm also going to think about initiating treatment against influenza for those individuals, and of course get that testing back as soon as possible so I can know the best way to manage them. The best treatment for influenza is the one you can get on board right now, stressing symptom improvement, but also preventing those severe complications of COVID-19 and influenza as well. So with that, I hope you enjoyed this program. It was fun giving it, and hopefully you can take this back to your practice and help improve people's lives. And what can beat that? Thank you very much. Be well.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.